We're excited to have you all here today to talk about the irritable larynx. And I am excited to join our panel, my co-moderator and friend, Dr. Blake Simpson from UT Health in San Antonio. He is the director of the University of Texas Voice Center. And then,
hello, everybody. Thanks, Sarah. Great to be here.
I can hear you.
You guys see me? Let's see.
I can see you now. Yes. And then we have Dr. Anne Vertigan, who's joining us from all the way from Australia at the John Hunter Hospital and Belmont Hospital in Adelaide, Australia. Welcome, Anne.
Hello, Sarah.
And then we have Dr. Laura Matrka, who is joining us from The Ohio State. She is associate professor there. Welcome.
Thank you.
We're very excited. Maybe I should turn on my video now, if I can figure that out. We are very excited to have everybody joining us today. So should we jump right in?
Yeah.
All right. I'm excited to kind of revisit this case. We had a panel on the irritable larynx last year at the Fall Voice Conference, and this I think will be hopefully an extension and maybe some new points on this topic. As we all know, the irritable larynx is an umbrella term that was first described by Morrison et al. In 1999. And it's a laryngeal dysfunction that's triggered by sensory stimulus and believed to originate in the central nervous system. So it includes laryngospasm, globus, chronic cough, and paradoxical vocal fold motion. And so just to spend a second defining each of these, let's talk. Laryngospasm is considered an uncontrolled or involuntary spasm of the vocal folds causing difficulty breathing and speaking. Globus is that nebulous lump in the throat that manifests for different people in different ways, but that lump. Chronic cough is a cough that lasts longer than 8 weeks in adults and longer than 4 weeks in children. And then paradoxical vocal fold motion is the abnormal vocal fold motion when the vocal folds adduct during inhalation. So as we're thinking about this today, we want to kind of keep in mind these 4 different definitions, and then we can maybe discuss what we think about each category under this umbrella term. So I'm trying to see you all here. So in keeping with this category, I consulted Dr. Google, as we all do.
Oh, nice.
Thank you. And started to type in irritable larynx, and the first thing that came up was irritable bowel syndrome. And in preparation, Blake and I were talking about the irritable larynx, and he mentioned, you know, nobody seems to make a big deal about the irritable bowel. Do they, Blake?
No, and I guess in the context, what you're saying, in the context of what you're saying, some people get very upset in our field that the term irritable larynx is used. And I think, you know, because they're like, well, that doesn't mean anything to me. I think it does. It's very meaningful. When we mention it, we kind of tend to know the type of patient we're talking about. Very much like, I'm sure GI doctors aren't crazy about the term irritable bowel syndrome, but it puts the patient in a certain category that they can all understand. So I think it's a perfectly good term to use. I don't get upset about it. I don't have a nomenclature issue like some people do.
Some people that we know. Well, and I think as we, you know, elaborate on this discussion, we can talk more about, you know, maybe this umbrella term really does have merit, and maybe these disorders that fall under this umbrella really are connected, which brings us to our next slide. Is irritable larynx an accepted term? So what do you, I'd like to throw it to our panelists. What do you guys think? Is this an accepted term that we should use in our practices?
I think I would say, and this kind of comes to your next question, is I think it's
appropriately non-specific, because when we start really breaking it down, we're implying that we understand this in a way that we don't. So I think it's fine to just call it irritable larynx. And if you really start to understand what's happening with this patient, which I don't think you do until you start treating them in your, few visits in, then you can adjust or refine. But I think irritable larynx really captures how poorly we understand it.
Yeah, I mean, there may be more of a neurogenic component in some people, and some people it's probably more of a vocal hygiene issue. There's different reasons that these, their larynx gets irritated, and but they're all falling under this umbrella term. And yeah, I think you have to tease out what components are the most contributory to their condition.
And I would say, Sarah, that I think there's probably subgroups under the irritable larynx umbrella, but I think it's really good to have an umbrella term because not all patients fit neatly into the subgroups.
Mm-hmm. And they have symptoms that cross maybe all of these
They
areas.
do.
Mm-hmm. So, and I think that's where when we were sort of talking about the like the whole Dr. Google thing, and irritable, people accept irritable bowel and irritable larynx very irritates people. The idea that it's a catch-all is I think we don't want to look at it as we're just dumping everything in there. We're critically thinking about what we're doing and trying to be specific about it, but sometimes we can only be so specific, like Dr. Matrka said. Is there such thing as irritable larynx that cannot be further categorized into chronic cough and PVFM? Any thoughts?
I would say sometimes I do come across patients that don't have a significant cough. They don't have PVFM, but they've still got a sensation of irritation in the larynx.
Mm-hmm.
So I don't think chronic cough and PVFM would cover all of those patients. I would also say that there are some patients where it's very difficult to determine whether they sit neatly within cough or PVFM because they've got symptoms of both that seem interconnected.
Mm-hmm. Sure. How does laryngeal hypersensitivity, and I'm going to add and cough hypersensitivity syndrome or neurogenic cough, how do all of these fit in? Because I find it honestly very confusing. Laryngeal hypersensitivity, I sort of get cough hypersensitivity, but when we're starting to talk about neurogenic cough, I feel like I don't have a good definition in my head of what does that actually mean.
I can't hear Ann now.
We lost Ann.
Mm-mm.
I think we lost Ann.
Let's see.
And we can't hear you.
She must not be able to hear us either.
Something about Australia. Allison, any way we can get her back on board?
Yeah, she can't hear me either, other than calling or emailing her.
I'm going to make her a sign.
And we can't hear you.
Oh, you can't hear me. Oh, okay.
Oh, there we go.
There we go.
We can hear you.
Is that working now?
You said some really smart stuff, I bet, though.
Oh, I did. It was brilliant. All right. So I'm having trouble with my speakers and with my microphone. So it sounds like. So, okay, I'll just have to keep switching them over. Can you hear me now?
Yes, we can hear you well now.
Okay, good. All right. So do you want me to say what I was just saying is
Yes.
Okay. The term cough hypersensitivity syndrome is it has come out of respiratory medicine literature, and I think within that there wasn't as much understanding about laryngeal disorders such as PVFM and globus. But I suspect that there is an overlap between them, and it probably would be good to have some discussion about the terminology and definitions at some stage.
Mm-hmm. Blake or Laura, do you have thoughts?
I was gonna, you just threw out there, sometimes you're not sure when to apply neurogenic to this, when it's something neurogenic. And I agree. I think a lot of times we we use that when there's some clear antecedent upper respiratory infection or when there's some clear nerve injury, either surgical or otherwise. I think in those cases, I'll tend to use neurogenic. You know, the patient that has, I have a patient that had a carotid endarterectomy. They injured the vagus nerve, and she got a paralyzed vocal cord, but she also developed a laryngospasm. And, you know, it seemed very clear in that case, this is somebody whose laryngospasm is neurogenically, that's a neurogenic injury, neurogenically propagated. And I feel more comfortable saying in those cases where I know a nerve was involved.
Yeah.
Laura, what do you think?
I was just going to say, I sometimes use it too, though, when part of it is ruling out obvious, you know, inflammation and things like that. But also things, you know, point tenderness over the neck, or some of these patients who, you know, they talk about the idea of wearing a turtleneck. They just can't fathom that idea where they're physically sensitive in this area. Particularly, we'll get to it later, I'm sure, but right over that thyroid region where the nerve enters. I mean, it's surprising how often you will find it if you look for it.
I want to come back to that specific, because I wonder, is it tension in the strat musculature in the thyrohyoid, or is it, so I think maybe we can revisit that topic and kind of hash that out in a little bit.
Yeah.
So let's just briefly touch on, and I think actually this is a nice lead in as we're talking about that, the multidisciplinary team. And I think, you know, our panel is made up of speech pathologists and laryngologists by design for a reason, because we really need to work together as a team. And I would say even going outside of our team, right, to pulmonologists, to GI, to psychologists or mental health providers. I think in this realm where we really need to function as a multidisciplinary team. Do you, we've probably all of us have worked in various settings. Do you feel that the model of care impacts your decision-making with this patient population? Like when you can sit in the room with your speech pathologist and to the physicians, when you can sit in the room with your speech pathologist and kind of hash it out and decide what you think, versus if you're in different situation and you feel point tenderness in the thyroid region, is that going to change your decision making?
Yeah, it's a huge advantage, obviously, seeing patients sort of interdisciplinary model, because I'm getting a reverb there. We will discuss the patient after we've seen them and done the strobe, and then we'll come in with a plan before we even come back into the patient's room. We're already going to know what we're going to tell them. We've talked about whether a SLN block is going to be done, sort of when we're going to plan the therapy. So it makes it a lot easier when we're on board right up front, instead of kind of scrambling or talking, you know, by phone. It's much easier to do it in an interdisciplinary fashion. Having not worked with a speech pathologist in the early years of my career, it was very difficult to take care of these patients.
Anne or Laura, do you have thoughts?
Yeah, look, I would have to agree with Blake. I would say, though, unfortunately, in my situation, most of our patients are not seen within a multidisciplinary team. We do have strong links, though, between multidisciplinary team members, so we often share information after we've seen the patient. And that's just circumstances under which we work. But I think if you have the opportunity for multidisciplinary input, it gives a much richer assessment and probably more timely assessment and less trial and error with the treatment.
So, Anne, do you feel like the referrals that you get, have you worked with your referring physicians to educate on what you can help with versus what you can't help with? How do you manage that?
Yeah, absolutely. Our referrals are excellent, and I think we did put quite a lot of time initially when we started our service into providing education to our referring specialists. So we get referrals from otolaryngology and from respiratory medicine. What we find is that the older doctors then train the younger ones in.
We've lost Anne again.
Mm-hmm.
Oops, sorry.
When Laura holds up that letter, that means we can't hear you.
Okay.
Thank you, Laura.
So I think we've kind of talked about these sorts of topics, and we'll address this as we go through our cases. So I'm going to jump right into the first case if everybody's ready. Mm-hmm. Anything else anybody wants to add? Okay. So I call this the rowing lineage case. We had a 16-year-old female present to our clinic. She is a competitive rower, and her basically generations back in her family went to Princeton and rowed. So there was a lot of pressure involved in this, her continuing along in her competitive rowing career. She was currently, when she presented, being recruited by multiple D1 programs. And so the pressure was real, not just from her family. She had the onset of breathing changes about 4 months prior to her presentation. It started with chest tightness, wheezing, and noisy breathing. She was initially treated by her pediatrician with inhalers, and she had some initial relief to the chest tightness, but as things went on, the inhalers became less effective and she began feeling throat tightness during the episodes. She would have no breathing or voice difficulties outside of rowing. And a few days before she presented to us, she had a recruiter who came to one of her practices, and within about 10 minutes of the practice, she began to have an episode. She came back, got off the boat, rested, went back in about 20 minutes, and then woke up the next day without a voice. And so when she presented, her VHI was 13. Her VHI 10, I'm sorry, was 13. We didn't have a complete list of all of her patient-reported outcome measures, which is the bane of clinical practice. But her VHI was 13. So she admitted to stress related to school, maintaining her grades because she wanted to go to a D1 school, and to rowing. A friend of hers had recently committed suicide, and she was seeing a mental health provider to help cope with her friend's recent suicide, and also for intermittent anxiety. So, what else do you want to know before I move on?
Did inhalers help her? Did you already tell us that? I'm sorry.
The inhalers did help her in the beginning, and then by the time she came to us, she was actually not using the inhalers anymore because they had stopped helping.
Okay, and that was
it really had changed from chest tightness to throat tightness.
Yeah.
Okay.
Can you hear me okay now?
Yes.
Yes.
Yes, okay. So I think I would want to know a little bit more specific information about her breathing. So whether it is more difficult to breathe in or breathe out, what sort of warning she gets before these episodes. So what sort of precipitating signs is she experiencing? I want to know whether she feels she has any control over her breathing at all. I'd want to know whether she's coughing as well as being short of breath. And I'd also want to know if the puffers, if the Ventolin was effective for her, how much of it she had to take before she found it was effective.
So she, I don't know the dosage of that off of hand, but she definitely by the time she reached us had stopped taking the inhalers because they weren't helping.
Okay.
As far as the triggers, she had, or the difficulty in or out, she had difficulty breathing in, not out. She did not feel like the breathing was within her control unless she completely stopped doing what she was doing. She really would have this sort of immediate response, especially at presentation. We can dig into that more with as we go down the line, but when she presented, she really just felt like they just happened to her and there was no warning sign. And there was one other question. Does she have control? I think I answered that. Did I cover it?
Did she have any?
Sorry.
Yeah, sorry. You go, Laura.
I was just going to ask any triggers besides exercise, and does she say that stress triggers it or it just results from it?
So she did not feel like stress was triggering it. She did feel like it resulted from it for sure. I mean, I think that with the recruiter coming, she started to make a connection between possibly more stress. But she did not feel like there were no other triggers. She never had any episodes except when she was rowing.
And one of our listeners wanted to know if she was seeing a psychologist.
Yes, she's seeing a psychologist. She had actually decreased the frequency of her psychological visits because she felt like she was coping with her friend's suicide better. So they had decreased, but she was still seeing the psychologist, yes.
Okay.
And was it just during rowing that her symptoms would?
It was just during rowing that she would have breathing difficulty, but a few days before the visit, she had lost her voice, and that was just when she woke up in the morning. She was completely aphonic. So let me play for you her voice. If you're wondering, these are the Cape V sentences. So she's aphonic. Could you hear it? Sort of?
Yeah.
Okay. And she was largely holding her breath while she was talking. Okay, and I'm going to play this exam. Hopefully it was a little choppy when we tested it, but hopefully you'll be able to get some information from this. E, and you're going to go like this. E, 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 E. So we could hear a normal throat clear at the end of that. Could you appreciate that?
Yes.
So in the exam, we see, normal abduction. She actually looks reasonably coordinated with the fast E sniffs. We can see that she doesn't get any voicing or any vocal fold vibration because of her voice production pattern. Tell me, I mean, this is an edited exam. We had tried a few things with her as far as sticking her tongue out. We had tried, to try to see if we could elicit voicing. We got that with the throat clear to see if we could elicit PVFM, any of that activity with the vocal folds. We did not. We did not try to trigger an episode that day, given all of the stress surrounding her situation. Questions, thoughts?
So I think in this situation, we might try some of the provocative techniques. We might try to have, if she didn't constrict during respiration, then we might try to have her breath hold. We would have her count as high as she could, different things like that, to see if then, when you'd expect the vocal cords to be nice and wide open, if then you start to see some constriction. We think of them also as provocative techniques that maybe will bring out any underlying tendency toward constriction. I think it's reasonable though sounds like the voice was the issue on this day. And I imagine she wasn't thinking or worried as much about her breathing, but I'm not sure.
Her breathing was really her primary complaint because of all of the, I think, is pressure around competing and the recruitment at that time. They were really hyper focused on her breathing, although they were a little thrown off by the fact that she was not able to, that she lost her voice. So what I think I'm hearing is you would try to trigger an episode.
Yeah.
Yeah. Ian? Would you want to trigger an episode?
Yeah, generally I try to. If I'm thinking that the patient's got PVFM, then I do try to trigger. Otherwise, we're making a diagnosis based on symptoms, which can be overlapping with other issues. So as much as we can, if we are scoping them, we do try to trigger the episodes.
Sarah, can we talk about like what would be the ideal situation for triggering an episode, like what equipment you would want to do that, and then kind of what we have in our clinics and what we have access to and what we've traditionally done, which may not be, ideal, right? I mean, I guess the best thing would be get a treadmill get them on the treadmill working out, maybe with an incline, and then scope them when they become symptomatic. But a lot of us don't have treadmills in our clinic. I have people run the stairs. They go run the stairs to see if we can elicit it, and then come back and get scoped. And Laura mentioned, I like your idea, Laura. Can you share that with what you guys sometimes do with your athletes?
We find it so hard, the college athletes especially, to really exert them or tire them out. We have them do burpees in the room. And if that's not enough, we'll make them add, it depends how they do burpees. We'll make them add a push-up in between. We'll make them do all kinds of crazy stuff. It's faster too, though, because they don't leave the room. We were talking earlier that she now has the right history, now that it's not in her chest anymore, now that she doesn't respond to inhalers and, the classic triggers. So you could maybe just go based on history, but I agree with Anne. I mean, to really know, it is sort of nice to see that constriction that correlates with what they describe as their symptoms.
Laura, I don't know if everybody universally knows what burpees are. Could you demonstrate them? I had my trainer made me do those, and I had to fire him really bad.
That's how we get people to stay until 9 o'clock. I'll do them right at the end.
That's the
Okay,
worst
cool.
exercise ever created.
It's the worst.
Would you want further testing? Would you want a bronchoscopy? Would you want PFTs? What would you want in an ideal world if this person came to your clinic?
I mean,
I would say, go ahead, Laura. No, I was gonna say almost everybody that gets sent to us has been sent from an allergist or a pulmonologist who's already done pulmonary function tests and has seen some sort of abnormality on the inspiratory limb and suspects it based on not responding to inhalers and the pattern on the PFTs. So that's usually already been done, I guess is my point.
Yeah.
We have a weird referral pattern in Columbus in that even family docs, allergists, everyone's really hyper aware, which is good and bad. It is a little sort of, I guess it throws you off a little bit sometimes when you get them from a family doc and they describe dyspnea and maybe cough and they've never seen a pulmonologist. They've definitely not had any testing. So when the testing's there, I like on the PFTs, I like to do the EDI where you take the FEV1 and you divide it by the peak expiratory flow rate. And if that's over 0.5, then I would probably bronch them or at least consider it. That's sort of an indicator of a higher chance that stenosis is at play. And it's always important to think about that. I think one of the pitfalls here, and we've all started to fall into it, talking about psychology and everything, is that, right off the bat, you think you know what's going on. You think, oh, it's functional. It's, it's IBS or ILS in this case. And so I think that's important, not to assume it's all psychologic, even when it seems really obviously psychologic.
Mm-hmm.
Great.
So somebody asked actually, what is the value of trying to trigger in the office? Like, what do you think, what information does this give us that's different than what we've seen just now?
I can take it if you want. I mean, one of the things I think is just that sometimes you don't see what you expect. I mean, occasionally we'll see widely AB ducted cords as we hear something. And that's really important. And sometimes, it'll bring out emotional stuff. Now that I've said we shouldn't focus on that too much. And then too, for us, my therapists want it, and they've really I'm usually with them, but they've really sort of taught me to do that. And then we always use just 2 basic techniques right there in the office to make sure that we see some response. We're sent actually a lot of COPD patients for BCD rule out and for PVFMD rule out, sorry. And for them, it's really important because occasionally the techniques make them worse. So those are the reasons we think it's important.
That's great. Do you ever see redundant tissue in the larynx that you think is contributing to the noise during breathing?
Absolutely, yeah. You have to be careful not to just want to remove everything that gets brought into the airway when someone's inspiring. But we did have a gal not long ago, a young girl who really there was some sort of positive reinforcement when she would make the noise. Her family would kind of get, everybody kind of get scared, and they'd pay attention to her. And we realized there's some positive reinforcement, and actually resected that tissue. And I rarely do that. And the noise went away, and she actually got a lot better. So it wouldn't be the typical thing I would do, but occasionally you see that. One of our panelists here was, or one of the persons asking questions here, it said wouldn't be stenosis because stenosis does not come and go. But I would say it's a tracheal bronch show malacia. Malacia does come and go based on effort. So I think tracheal bronch is important. You're not ruling out stenosis, you're ruling out other things where there's airway collapse. So just and that person also said this is clearly a case of somatization. What do the panelists think about that?
Well, there's there's evidence that there's a study that showed the actual personality types and sort of used some different, personality testing to show that it fit the pattern of a conversion disorder. So that's, again, goes against what I think is the right way to approach these patients, but you have to keep in mind that it can act that way. Maybe most often in that typical stereotypical patient, the type A young teenage woman.
I mean, in this case, I think that we went down the path of she needs behavioral intervention and she needs to continue work with her psychologist. So jumping into treatment, we started with respiratory retraining and some voice therapy, and all with the caveat that as we were doing this, she needed to continue work with her mental health provider. And just, I mean, primarily for the fact that sports, professional athletes, college athletes work with mental health providers, right? They work with on stress management and these sorts of things. And if anything, not to make assumptions that it's from her stress, but working on these things will help manage it, because it's probably not going to go away based on the goals that she has for her athletic and school career. So we actually did about 4 sessions over 1 month. We worked on, one of the things we started with was massage, tongue stretches, postural adjustments, stretching, that sort of thing, just to try to get her loosened up and in her body and aware of what was going on. We also started immediately on the day of her initial visit with metered breathing. And I know people call these things different things, per slip breathing. There's multiple different names. We call it metered breathing because we typically teach it in a rhythm. We worked on it at rest, during activity, and her family, her mom was super committed, and actually we cleared out our conference room and they brought the rowing machine in for our therapy sessions, and we we got her heart rate up and got her really working so that we could implement the techniques while she was rowing. Do you have thoughts about that, Anne, that you would like to add?
Yeah, look, I think that's excellent. I'd probably do very similar things to that. I think it's important to make sure the patient can do the exercises when they're not doing any physical activity, and then gradually increase the activity. I think the other point that I make with patients is that they need to not push through any breathlessness, so that if they start to become breathless, that they back off the pace and get their breathing under control rather than ignore it. And that's completely around the wrong way, the way we normally exercise. Normally, if we exercise, our breathing catches up. But in this case, they need to slow their breathing down.
And that's a really great point. And I think that when we initially started with her at rest, during activity, like during walking around or walking the steps or running the steps, it felt really easy for her to do all of that. And then when we got on the rower, that her tendency was just to push, right? And so that starting and you asked this initially, Anne, about what were the precursors? We worked a lot on spending time about what is your body telling you before you actually get to this point? And can you catch it earlier? Can you be more aware and not of, I can't breathe, but of how am I feeling? So that it's a productive pattern, which was helpful for her. we also, obviously, because she was aphonic, worked on voice exercises. In this context, actually, she was holding her breath with everything. So she would take a breath, she would exhale. And so we actually worked on gargling and cup bubbles. She would get normal voice right away. She couldn't maintain that. She'd go right back to the breath holding pattern. So then we started working on, can you whisper with an exhale? Can you actually whisper with an exhale? And so we started there and then transitioned into resonant voice. After about the second session, she had a normal voice, but she would easily lose her voice if she started to go into a breathing episode, or even in anticipation of practice, she would lose her voice. So there was a lot wrapped up in this, hence the continued work with her mental health provider. Any thoughts or additional points that you think we should make on the therapy end, Anne, or Blake and Laura?
I guess the only other thing sometimes I will do is if I might work with the patient to get them to exhale during the most strenuous part of the exercise, so that they're not pushing quite so much at the laryngeal level.
Any questions that you would have, Blake or Laura? I'm going to move on to the next slide.
Yeah, go ahead.
So 6 months later, so she was doing great. I would get an intermittent email from her mom saying, you know, she's doing good, this is what's happening. And then she had a relapse. She had a hip injury she was recovering from. She was not in her usual state of conditioning. And when she went back to practice, she developed breathing difficulty with throat tightness and voice loss again. That after that practice, or at that point, she went to the ER. Her O2 stats were good. She was given Ativan mist inhaler, and she returned to, and she was able to get discharged. And then she came to see us. I don't have another, I'm not going to show you another exam because basically it was the same presentation as she had before. And really we did one SLP session to get her back to baseline, spent a lot of time counseling on empowering her to feel like, you know, in these situations where something changes, where it's not in your normal routine, it's important to be proactive and prevent these things from happening, because you are in control, and empower her to feel like she's in control. And then I didn't see her back. So would you, in a relapse situation like this, would you treat it any differently than we did? Would you think something else was going on? Would you try more testing?
I don't know. It just seems I've been doing this a long time, and it seems the more patients I've seen with different manifestations of ILS, the more I've seen people come back years later with the same problem, right? I mean, I've been in the same town for 23 years, and so many of these patients will show back up 2, 3, 4, sometimes 10 or 12 years later. Same problem. Usually a URI set them off, or some sort of rotative force. So it's definitely a recalcitrant problem.
So do you think we're missing something in our diagnosis or in our treatment, or you think it's just they're more sensitive to whatever the triggers might be, and maybe I don't know, like, is there a self-efficacy thing that they don't then use the techniques they learned before, or that they don't remember them maybe if it's years later?
I think
I
it
think
is.
sometimes they don't remember them. And I think it's a bit like if you haven't played the piano for a long time and you go to pick it up again, you're going to be rusty. And I think sometimes patients get a bit rusty on their techniques and they might need a refresher. I think the fact that she came back and improved in one session is probably evidence of that. I think if they don't improve after they've relapsed, then we probably do need to look in a bit more detail. And I've had somebody who relapsed, came back, and it was lung cancer, and we thought it was the same issue that she'd had previously. So I think if they don't improve quickly, we need to look into it a bit more.
Mhm.
Yeah, I agree with Blake though. I mean, I occasionally, depending on the person's personality, will even tell them up front, you know, this is sort of a long-standing condition or predisposition that you probably have. So just watch out if you get an allergy flare or a cold or something.
Let's transition over, Blake, to you and see if we can share a case on one of your cases. While we're doing that, somebody asked a question about do you refer to PT for massage or have patients do cross training? And do you find benefit with this? I think, you know, it depends on what the patient can handle and what they have access to and their needs. Yes, we do sometimes refer to PT if people need it.
Someone had a question too about diet. I guess especially in the collegiate or high school athletes in terms of eating before their performances, and I guess the issues of reflux and whatnot. Do you have an opinion on that, the panelists? The diet has much of an influence on these patients? I mean, it certainly can.
I've had a couple recalcitrant cases where that was the cause. They ended up just having terrible reflux and they couldn't eat for like 3 or 4 hours before exercising. So, you know, the patient I'm thinking of actually ended up having to get a Nissen as a teenager before her breathing cleared up. But her breathing dramatically cleared up when she did that. So, and it was our SLP who figured that out. I mean, that didn't come out at the first visit.
Sometimes it takes time to get to that, like where you can break it down enough and peel away enough layers that you can hone in on what the primary trigger is.
That's right.
Do you find that most of your patients in this group are in a normal weight range? Because I would have to say most of ours are in the obese range.
In Columbus, we get, like I say, these bizarre COPD referrals. Well, they're not bizarre, they're typical COPD referrals. So that changes things, but yeah. I don't know what to say
Not thought about that. Sarah?
I feel like it's a variety. I think in the case that I presented you with the athlete, I mean, most of those patients are in great shape. I think, but some of our other patients, it's a mixed bag. Mm-hmm.
All right, well, let's get to the chronic cough, which is something near and dear to so many of our hearts, right? So I've got a good case that we can enjoy here, if I can get it to advance. Let's see. Locked up here. Sarah, if you have a second when my computer's kind of giving me fits here. Hold on a second.
Let's see.
Let me see if I can get this going. Hold on. Okay, now I got it. Is everybody still there?
Okay. Still here.
All right. So my case is a 68-year-old female that had a 15-year history of coughing and throat clearing and this perception that she had a weak voice. And her cough was non-productive and usually preceded by a feeling of a tickle or mucus in her throat. And the general triggers she had were strong scents and perfume, cleaning chemicals, and cigarette smoke that she was exposed to. That's sort of her, I don't know, we have 20 minutes. I don't want to get 17 minutes. I don't want to get too much into the weeds with the history since these tend to be similar, but I was just curious of the group here. What triggers do you tend to see with this irritable larynx and cough patients? I just listed a few of them. Is there anything else you ask in the history when you see these patients?
Voice use.
Voice use, of course, yeah, and that was the case with her too, singing and voice use.
Mm-hmm.
Laughing, you know, like any of those like quick breathing activities sometimes will trigger a cough.
Dan?
And then we also find when we test people and we do voice testing, so if we get them to read a paragraph or do a scale or sustained phonation, that will see that trigger cough, even though cough might not be triggered during the case history.
So in terms of medical history, she was diagnosed with GERD and was treated with twice-a-day proton pump inhibitors for months and eventually underwent a Nissen fundoplication many years ago, and her heartburn went away, but really her cough did not change. It's a long-standing cough. She had seasonal allergies and she took antihistamines just during her allergy season. Again, no effect on her cough. And she did actually have asthma and had been on multiple inhalers, including steroid inhalers in the past, which helped her breathing, but really didn't have effect on this cough. And it mentioned Xanax had reduced her cough, but she wasn't currently on it, but had noticed it one time when she was taking it for other reasons. She works as a minister, and so she's 68. She's kind of getting near the end of her career and was even thinking of retiring because she was having a lot of difficulty with her sermons and trying to sing due to the cough that developed when speaking or singing. And you see her vocal hygiene there.
We don't have your slides.
Oh, you don't? Well,
I
that's
don't.
correct. Let's see, share this again. See if I can get this to come out.
There we go.
There we go.
How's that?
Better.
Perfect. All right, so I'm curious because as far as I'm concerned, when you look back at those, what she had been treated for, I think a lot of this had already been managed. Like when I looked at her, I wasn't thinking, oh, her GERD could be out of control again. Her allergies are an issue. We need to do more asthma testing. Kind of, I think in that patient, I felt like I had checked off a lot of the boxes, but I'm just curious, the group here and specifically Laura, are you routinely retest any of these people when you're thinking this is sort of neurogenic or irritable larynx related cough?
Honestly, and I wonder if you have this situation too, it depends a little bit on where they came from. If they came from one of the really tiny seriously, really tiny outlying hospitals, sometimes I do. And sometimes I'll dig a little deeper and find that what they thought they had done wasn't quite what they had done. But in general, I mean, I kind of follow the patient's lead. You know, if they say like, please don't say the word reflux again, then sometimes I'll just let it be. But there's never, I mean, every time there's a panel on cough, there's never a simple answer here. Sometimes you just have to dig through it all, and it's just, you know, it's case by case.
Yeah. Okay. Yeah, this keeps, I'm sorry guys, this continues to give me trouble.
So while you're working on that, Blake, a question from one of the attendees is, when a patient tells you, complains of cough but doesn't cough during the visit, how do you factor that in? Because, I mean,
Some happens all the time.
yeah, some people you hear coughing in the waiting room, right? And we're like, here they come. And other people, they don't cough, right?
Well, sometimes, I mean, I don't know. Sometimes you can spray them, you can trigger it. A lot of times it just depends what they told you their triggers were. You know, if they're telling you they cough all day long, they never go 5 minutes without coughing, that's a little different. But if they told you very specifically that there's only certain things that make you cough, then you don't worry too much, I guess.
Can you see my slides now? I'm having problems with the interface. I apologize, but really on her exam, the only thing that was remarkable, and hopefully this will get a raised eyebrow from Dr. Matrka, but she had, when you palpated over her left posterior thyroid space, it actually triggered a cough. So she volunteered to me. She pointed to her left posterior thyroid space and say, I feel something here. It's a dryness, it's a tickle, it's an irritation. And I said, oh yeah? So I put my finger over there and sure enough, just palpation over that area elicited the cough. And I'm curious, because I know you're a believer in the superior laryngeal nerve block, Laura, so I'm preaching to the choir here, but do you have any comments on when you see cough patients and your I guess your notion of that part of the physical exam?
Yeah. I mean, it's become a
patient with irritable larynx.
Yeah, it's become crucial. And yeah, you're right, not just for cough, but for the whole spectrum. So I pretty much always try to do that now. And so there's 3 things. Does it trigger a cough? Is it tender? You know, if I squeeze and they jump, I say, which side was that? You know, which side set you off? And then, as you said, if they actually feel it more on one side or the other. That one's a little bit less common, but I don't know, the more of these nerve blocks that I do, the more I do. Because they're pretty low risk and they're better tolerated than you would think for a needle in the neck. And it's, you know, that and dramatic diet changes are the only things I've ever seen really take care of some of these recalcitrant cases. So yes, I'm a believer.
How do you differentiate between, I feel like because I usually palpate everybody's neck as part of our voice evaluation as well. And sometimes when I trigger a cough, I think of it as a tension or behavioral indicator. So I wonder, not always, but especially in that thyrohyoid or right in the base of suprahyoid area. So how do we differentiate somebody that you might, that might be somebody that has laryngeal tension and that might benefit from behavioral intervention versus somebody that might benefit from a superior laryngeal nerve block?
That's a really good question. I think sometimes the voice quality can help you. And I think sometimes, even if I do think there's some behavioral or psychologic overlay, I'm not a psychologist, but I'm a surgeon. And so I can do the shot and I can't do the therapy. I don't know. It's, sometimes I do what I can for them with them right there, especially if they drove 3 hours, and maybe that's part of why I'm doing it more. It's important to recognize for sure. And the voice might be the only thing that really, really helps me, because some of them have a very strange voice on top of and I think it's because they're trying not to cough in some cases, but sometimes that helps. I don't know. Blake, Anne, what do you guys think?
Who knows why the nerve block works in some patients. It could truly be the nerve block effect, which I think is one of the strong reasons it works with cough. But in muscle tension dysphonia, it may just be that you're putting an anesthetic and a steroid into the strap muscles. There could be some localized defect there for all we know. I don't know. But I agree with Laura. A lot of times we see these patients, and as the MD part of this team, we sometimes feel helpless because we know a lot of this is going to respond to therapy. We know therapy is a cornerstone of getting these patients better and keeping them better. And we're trying to see if we can find something that will help them. And, neuromodulators are great, and we use those a lot. But I agree with Laura, when you could just do something quick that has a pretty nice side effect profile. You don't really get, neuromodulators can be poorly tolerated, and something like a nerve block, if it's going to help them a little bit, and just at least get them kick-started before they start their therapy is a nice thing. And I think that's probably why I use it a lot on these patients. And it can be very effective. Sometimes that's all they need, but most cases, it's a multidisciplinary approach. I'm rarely going to fix someone completely who's had cough for 15 years. You're not going to fix them with a single nerve block, that's for sure. But it's going to help. I don't know if anything's working out on my computer, so let's see.
Can I ask a quick question?
There's a division of white light
Are you able to see this?
into many beautiful colors. These take the shape of a long round arch. He. E, 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 E,
Any comments on the strobe? Anything that stands out, or do you put any importance in these type of exams in a cough patient? Just out of curiosity. She's hoarse as well. It's not just cough. So.
I know that some people will debate, like, do you need a stroboscopy in somebody with a cough? But personally, I think that it's super helpful, because sometimes if people have subtle mucosal abnormalities or some vocal fold scarring, and they're using their voice in a certain way that triggers the cough, that's going to give me information and how to treat them behaviorally. So even though at her we're not seeing anything really glaring, I think it is helpful to have that information on each patient.
I'll latch on to the glottic insufficiency sometimes if I'm really having trouble, because I've had just a couple where Restylane injection or something like that would help a cough. So if voice is a trigger.
Yeah, that can. If somebody has glottic insufficiency, I've had a few patients, in fact, Lucia and Salika published on it, that can actually resolve their cough if you correct their glottic insufficiency. So I definitely think that that's a thing. I don't do it as much as I used to, but it's definitely a real thing. So I think it's important. But, and she was dysphonic, so it was perfectly appropriate to get that. And that was part of her treatment, obviously, too, because she had a muscle tension component that went along with this.
Mm-hmm.
Could I ask a quick question of Anne and Sarah?
Yeah.
So our SLPs have sort of trained me on a chronic cough patient not to think about the whole PVFMD spectrum as sort of we're taught to, unless they specifically complain of dyspnea, because they just say we've done therapy for enough years for that we've seen that if they don't also have dyspnea, then treating for PVFMD doesn't help. What do you guys think about that?
and you should take this.
Yeah, I guess we've just looked at some data we're collecting at the moment, and where we've just looked at patients with chronic cough who didn't have any symptoms of PVFM. And when we did their laryngoscopies and we gave them a provocation, we actually triggered PVFM. And so these were patients in their history that they didn't look as though they had it. I think we just need to be a bit mindful that these disorders can overlap. And when you give patient-reported outcome measures to patients with chronic cough, they will score high on the PVFM measures, and the same if you give things like the Leicester Cough Questionnaire to PVFM patients, they will also score highly and higher than normal controls, and often not much different from the chronic cough patients. So I probably would take a slightly different stance on that and just be open to the possibility of it being present.
I guess assuming a group where they all have scope evidence of paradoxic movement, if you go just on symptoms, do you see any different in response to therapy, in success of therapy?
I think if I see PVFM on the scope, I often find they're the ones that won't respond as well just to very simple cough suppression strategies, and sometimes we do need to address the laryngeal constriction that we see on the scope. But I think that's certainly an area that we need to research a lot more at the moment. These are my thoughts based on what I'm seeing clinically and with some of our research data, but I think we need a lot more data to
I
work that
agree.
out.
Those people for it, they almost always have that paradoxic movement. I think we totally see that as well.
Or some sort of twitchy larynx.
Yes.
Yeah.
Larynx.
Yeah.
I can't believe we only have 4 minutes left, Sarah.
I know.
And
we're thinking about having more cases.
Honestly, we could talk, and then I don't know that anybody would want us to, but we could probably talk another 3 hours about all these. I'll give you some follow-up about this case. And actually, I've taken care of this patient for years, but we did do a superiorlaryngeal nerve block on her, the side of her trigger, and her cough got dramatically better. Her CSI went down to 6. And she started therapy with our speech pathologist, who worked on metered breathing and substitution behaviors, swallowing. Worked on her triggers and avoidance of those, did some resonant voice therapy, worked on hydration, the usual stuff. And she would come back to me for nerve blocks about every 4 to 6 weeks. And over about an 8-month period, we did 7 nerve blocks because they would kind of, wear off. And after a while, she became more and more reliant on just using her therapy techniques for maintaining herself to be cough-free. And after about 8 months of sessions and nerve blocks, she was completely asymptomatic. She retired from the profession. And 2 years later, she came back to see me because she had had a relapse. And she already knew what to do. She kept, we're a little old-fashioned here in San Antonio, but she had CDs that she had used to work with her speech pathologist here. And she just pulled out her old CD. She came in and she got 2 nerve blocks, same side, over a 2-month period, and became symptom-free again. I haven't seen her in probably another few months. So again, goes back to the sort of the recurrent nature of these problems. And if they've got all the materials to work with, they can usually get better. I mean, we never had to put her on a neuromodulator, which I'm sorry we didn't get a chance to talk about neuromodulators. So let me throw it out real quick to Laura. What are your favorite neuromodulators for chronic cough?
Oh, I mean, I'm using them less all the time. Amitriptyline, I'll say.
So Elavil, amitriptyline is your favorite one. I usually start off with 10 milligrams at night, and we go up 10 milligrams more each week. Is that how you guys do it?
1 to 2
a dose.
Yeah, exactly.
What dose will you go up to? What's the highest dose you'll go up to?
I mean, I tell them if you're going up slowly, I don't care if you go all the way up to 100. I've never had anyone do it. 30 to 40 is as high as anyone goes, either because of side effects or because they get benefit. I may have maybe 1 patient on 50.
I usually cap out at 60. And I like tramadol. I don't know if you ever use, Ultram tramadol. That's a really good one. Greg Dion had a nice paper about that with milanamine, about the use of tramadol, and it's none of them have a great side effect profile, but it's pretty reasonable. I do not like gabapentin or pregabalin. Patients just dislike it. They just have too many side effects. And you can get people on it, and you can ramp up, and they can do very well. I don't want people to think I don't believe the medication works. I do believe it does work. I just think there are things with better side effect profiles. perhaps.
We talked about this beforehand. We both independently said that.
Yes, we did. No, we did. We had not talked about this, but I'm glad you agree with me.
And what neuromodulator was used in the study that you did?
So we used gabapentin, and that was combined with speech pathology. And our team previous to that had done one with gabapentin.
There was one last question, if we can fit it in the last moment, for Blake and Laura. What dosage do you use for the nerve block, and what medication and what dosage?
Can you see my screen or no?
Yep.
Yep.
So you can see the illustration here. So I don't know what Laura uses. This is kind of what we've done in San Antonio. It's a CC of 0.5% Marcaine and a CC of Kenalog 40. And we mix that together and use a 27 gauge needle. And it's really not that hard to find this area. I usually will palpate the space right here with my thumb. You can feel it pretty easily if you put your hands up to your thyroid, posterior thyroid space. Your thumb fits quite nicely in a little fossa there, a little depression. And I just go down to that area. You can feel it hit the thyroid membrane, and then I deposit the medication. You got to pull back on the needle. I mean, it's a particulate steroid, and it's a local anesthetic. You don't want to get it intravascular, so I'm always very careful to pull back on the needle to make sure I'm not intravascular. There's actually a CPT code for it, 64408, that pays, so you do get reimbursed for this, and it could work anywhere from 2 weeks to several months. It just varies, but it's not unusual for someone to come back and need another treatment, but it can be repeated.
I have a few like Blake where they came back a few times. I stopped using the Kenalog after the third one, at least if it's within like a year or something. And I have a couple of patients where I've just used I use lidocaine instead of Marcaine because I have them stay in PO for an hour so they don't cough or choke. But and that's worked too. And that's where maybe it's more placebo, or maybe it is because you're just cutting off the nerve transmission for a period of time. And I tell them we think maybe it resets at a more normal threshold. It's a lot of fairy dust. And
no, I think it's true. If you talk to the pain and management specialists in anesthesia, and that's how I kind of came up with the nerve block. I called one of my friends that does that for a living when I started getting the idea of doing this for cough.
yeah,
And he said, I was like, how do these work?
yeah.
Like, how can you inject a local, anesthetic and have it work for weeks? And he said, it's just like rebooting the computer. That's all he could come up with, really. And it's kind of true. And I tell patients that, we're going to reboot your computer. And that's why I think these have some sort of, longer lasting effect. Or perhaps they're placebo. It doesn't matter. They're getting better.
Or placebo, yeah.
Well, on that note, before we all turn into pumpkins, I want to thank all of our panelists. Thank you to my co-moderator, Dr. Simpson. Thank you all for joining us out there on the internet. And we'll see you soon, hopefully at the next Fall Voice webinar that's coming up in a month, and then at the Fall Voice Conference in October. So we'll see you all then. All right.
Thanks everybody.
Okay,
Bye-bye.
thank you.
Bye.